I'm Dr. Jessica Colburn, and today we will be discussing diabetes. Diabetes comes from the Greek word that means to siphon or run through. So our early physicians were trying to characterize a syndrome where their patients were making very, very large amounts of very dilute urine. The water was just running through them. And they actually found two different types: diabetes insipidus, which insipid is from the Latin meaning lacking taste or flavorless, and they found mellitus, which is again from the Latin but meaning sweet. So our early physicians found that there were actually two causes of their patients making a very, very dilute urine. One cause caused a flavorless urine. The other caused a sweet urine. Diabetes insipidus is a rare condition. There's two types. Central diabetes insipidus is a lack of vasopressin, which is also called antidiuretic hormone or ADH. It's caused by damage, cysts, neoplasia, a problem in the hypothalamus or the pituitary gland. Our hypothalamus typically recognizes dehydration by the osmoreceptors, and it signals the pituitary to release ADH. ADH then comes down and acts on the kidney, telling the kidney to stop diuresis, resorb water from the distal tubule, and prevent the patient from getting more dehydrated. Diabetes insipidus, the other type is called nephrogenic DI, and that is an inability of the kidneys themselves to respond to ADH. This can be congenital, but that's very rare. Typically, it is caused by E. coli. Endotoxins can act on the renal tubules and prevent them from being able to respond to ADH. This is very common when we have bladder infections secondary to E. coli, prostatitis, or pyometra. It can also be caused by electrolyte imbalances like hypercalcemia, hyperaldosteronism, hyperadrenal cortisolism. So when we have patients with Cushing's disease or receiving exogenous steroids, this is why they produce so much urine. And in humans, ethanol is a big cause. So when we drink a lot, our kidneys can no longer respond to ADH. So we become tasteless and we produce a lot of tasteless urine. We also wake up very dehydrated and with a headache because of this. So in diabetes insipidus, you have excessive amounts of dilute urine because the kidneys can't concentrate urine. There's excessive thirst to try to prevent dehydration. Central DI is rare. It's difficult to diagnose, and usually we have to do a water deprivation test to diagnose this, and it's difficult to treat. In nephrogenic DI, we typically treat the underlying cause. Now, diabetes mellitus. This is characterized by hyperglycemia due to a lack of or an inability to respond to insulin. When blood glucose is over 300, it overcomes the kidney's ability to resorb glucose from the renal tubules and then causes an osmotic diuresis. Then we develop polydipsia to prevent that dehydration. Here we see the process is complicated, but it boils down to insulin receptors trigger the glucose channels to open, let glucose into the cell. But now insulin is also very important in the role of regulating gluconeogenesis, glycogen breakdown, protein breakdown, and fat breakdown, and that's important. We'll find later on when we discuss DKA. So here is a cartoon of normal versus diabetic renal tubules. Glucose always filters into the renal tubules, but with normal amounts of glucose, the tubules can reabsorb it. If large amounts of glucose, the tubules cannot, and again, we get an osmotic diuresis and a lot of urine. So when we diagnose diabetes mellitus, typically we see a patient that is PUPD, polyphagic, eating a lot but still losing weight. They have a persistent hyperglycemia and a persistent glucoseuria. We might also note in dogs cataracts. A lack of grooming in cats is very common. They, again, in cats, we notice a diabetic neuropathy, much more in dogs. It can happen in either, but it's a rear limb weakness where they end up very flat-footed, kind of walking on their hocks. And sometimes they will have an acetone or fruity smelling breath. There, again, are two types of diabetes mellitus. Type 1 is when the pancreas fails to produce insulin. It is treated with insulin injections and diet. This occurs in all dogs and most cats. In type 2, the pancreas can regain the ability to release insulin. It's more of an insulin resistance, and with dietary changes we can correct that. Some cats, if caught early in the disease process, do fit into this category. Treatment in dogs is typically a high fiber diet twice daily, corresponding to their insulin injections. The most common insulin used in dogs are human recombinant NPH or Lente, or the only veterinary labeled insulin, Vetslin, which is porcine in origin. In cats, we have better success with low carb diets, or we jokingly say the Catkins diet. This is things such as DM, MD, or glycobalance. There are a lot of over-the-counter foods, though, if a client is willing to do the research, that actually meet the qualifications of a high-protein, low-carbohydrate diet. Again, we give insulin every 12 hours with a meal. And in cats, we can use Vetslin, but I tend to use Glargine, and other vets prefer PZI. In cats, if diet is corrected and insulin therapy is started early, cats can return to a non-diabetic state. Canned food is more likely to get this result than a dry food, but diet alone will not typically cause this conversion. And while this state of conversion is desired, we don't want our patients to be diabetic. It can be very, very dangerous if a client isn't aware that this can happen and observant of their pet. If we are supplementing insulin and a cat suddenly starts making insulin on their own, then they can basically get an insulin overdose, become life-threateningly low blood sugar, hypoglycemia, and they can die from that. So we need to make sure our clients know that this is a problem. So if they notice their patient becoming weak after an insulin injection, they bring them in and we can diagnose that this has happened. When we are trying to control diabetes, we have better success if any comorbidities are treated, any cause of inflammation or infection. And the most common problems that will cause a persistent or more severe insulin resistance is periodontal disease and bladder infections. Cushing's disease, hyperadrenal will also perpetuate an insulin resistance, so it's important that we identify those patients that have Cushing's and get that under control as well. The goal of treatment in animals is not to maintain normal blood sugar levels like it is in people. In people, they can give themselves insulin injections with every meal, or they have a pump. They can monitor themselves much more closely. In animals, our goal is to prevent the clinical signs that our clients find annoying. If we keep the blood sugar between about 100 and 300, we can minimize PUPD, stabilize the patient's weight, prevent cataracts. We don't want our blood sugar to fall much below 100 though, because again, hypoglycemia can be life-threatening. Diabetic ketoacidosis. This is a diabetic emergency state. It is starvation in the midst of plenty. We have plenty of energy in our cells, or in our blood circulating as glucose, but our cells cannot take it up. This results in a metabolic acidosis, hyperosmolality, ketonemia, electrolyte derangements, and severe dehydration. Our bodies know they need energy, but they can't absorb the glucose that's circulating again. So they break down fat into ketones, they break down proteins into amino acids, they break down glycogen to make more glucose, and they do glucose neogenesis, trying to make more glucose. But they're not responding, so they release catecholamines and cortisol, stress hormones, which ramp up this whole system and make things worse. This also results in a lot of electrolyte disorders, acidosis. We get more acidotic, more dehydrated. The cycle continues. This results in shock. These patients present vomiting. They're not drinking, but they're still urinating a lot. And they're severely acidotic, which causes depression, coma, and even death. These patients, in my experience, are most often dogs and cats the owners did not know were diabetic. But it can sometimes be a known diabetic that has decompensated due to another problem such as pancreatitis. Blood work shows hyperglycemia, azotemia, typically hypokalemia, hyponatremia, hypochloremia, because all of these electrolytes are being filtered out with this excessive urine output. A urinalysis will show glucoseuria and ketonuria, but the ketone squares on our urine strips are not always reliable. So even if it doesn't measure ketones, if I have a sick diabetic patient, that meets the clinical signs, then I usually presume that they are ketoacidotic. You will notice a very clear urine that looks like water, but the urine has a very high specific gravity, and it's the glucose in that urine that is causing that high specific gravity. The first step to treatment is to correct dehydration, or at least begin to correct it. Usually we will choose physiologic saline as our fluid replacement fluid, and we have to calculate our fluid needs. Now, this is one of my pet peeves, and I expect you to be able to do these calculations. There are a lot of veterinarians out there that decide to pick a rate like twice maintenance, and they stick with that no matter what when they're treating a diabetic ketoacidotic patient. And that will not be effective, because if your patient is making 200 mils of urine an hour and you're only replacing 120 mils of urine an hour, then you are behind the ball. So you have to do the math. You have to calculate maintenance, which I usually use 60 mils per kg per day. You have to add the replacement of what they are already missing from dehydration. So their weight in kgs times the percent dehydration times 1,000 mils per kg. This number always ends up shockingly high. You have to add concurrent losses. You have to measure the urine in these guys. And I like to do that by weighing their pee pads or placing a urinary catheter and actually collecting their urine in a urine bag and measuring it. So you add all of this together and replace it over 24 hours, but you have to assess your patient, check how much urine they're making. You have to make adjustments very, very frequently to get these guys hydrated. Next, we correct our electrolytes. Again, these guys are frequently hypokalemic, but even if they aren't on the initial blood work, once we start insulin, they will become hypokalemic. Insulin drives potassium into the cells, and the potassium in the blood is going to drop very, very quickly. They have a total body potassium deficit, again, because they are urinating out a lot of potassium, but it is leaving their cells, going into the intravascular space, and then being peed out. So we do blood work, even if it's normal with initial blood work, they have a total body potassium depletion. Hypophosphatemia can cause a hemolytic anemia. Electrolytes need to be checked every 12 hours and supplementation changed to meet that patient's needs, okay? So remember our sodium-potassium pumps. When glucose comes into a cell, it brings sodium with it, but then the cell actively pumps out that sodium, bringing in potassium to replace that positive ion. After a few hours of appropriate fluid therapy, we begin our regular insulin R. This is a human recombinant fast-acting insulin. You can give injections, IM, every 1 to 2 hours, or begin an insulin CRI. If you do a CRI, and I love CRIs, typically we mix it up in a 250 ml bag, you have to run out about the first 50 mils because insulin does bind to plastic. And if you don't coat your tube, your IV tube, with insulin before you start therapy, then as you are doing this CRI, the insulin will bind to the plastic and your patient won't get any. You need to saturate that plastic with insulin and then hook the line up to the patient. So CRIs are intimidating, but once you get used to them, they are awesome. They're very effective. They're easier on the patient, and the patient typically returns to normal faster than with the injections in my experience. These charts are from my favorite critical care book. I highly recommend it. It's called Small Animal Emergency and Critical Care Medicine. It's not that expensive, and it's got a lot of great, easy charts to help you with things. You'll notice, though, that as the blood glucose approaches normal, we keep giving insulin.